Please give a warm welcome to Dr. Vishnu Sundaresan.
Hello, everyone. I cannot see much of you, but I'm hoping that it's clear from there. So my name is Vishnu Sundaresan. I'm a program manager in the Defense Sciences Office. So today, I'm going to share with you one of the recent technology breakthroughs that came out of Defense Sciences Office. And this is primarily to address or enable a new capability for pharmaceutical manufacturing. While this technology was primarily intended for warfighter healthcare, I'm going to talk to you and share with you how this was pivoted to kind of build upon Dr. Flagg's point that, look, DoD technology can be used for other things, that it was pivoted to address some of the emerging needs that we had with the supply chain disruptions for critical care medicines. So let's just take a look at how pharmaceuticals are manufactured with today's footprint. So like with most products, engineered products, pharmaceuticals have a global footprint. It starts off with what you would call as a fine chemical or a starting chemical that is produced by oil and gas industry. Well, thank you, Texas. And then these chemicals are converted into active ingredients that is the key component of your drug. These active ingredients are then combined with other inactive ingredients and solvents and made into a syrup, capsule, whatnot, and it is provided to you. From looking at the market, what was observed was that the United States produces almost a majority or a lion's share of the global supply chain for these pharmaceuticals or the starting chemicals. But then these starting chemicals are shipped overseas and converted into active ingredients and some overseas capability for finished drug products. And as we understand, this creates a vulnerability in any supply chain. Whenever you have a global footprint, you always try to balance efficiency versus resiliency, and again, you're opening yourself up for disruptions. And this actually became real very quickly during COVID pandemic. And as we see on the chart there, you have at least, out of the cohort of some essential medicines, 85% of them are vulnerable to trade disputes in Southeast Asia or rolling waves of shutdowns that could happen during the pandemic. So now as an example, on the next chart, what I have is a drug that was critical during COVID. This, as the name goes, is satracurium. It is a muscle relaxant that was critical for intubating patients while they were under acute respiratory syndrome or distress. So we had these rolling waves of shutdowns, and we ran into critical shortfall of these drugs. And as a consequence, FDA still maintains a list of critical drugs that are in short supply so that we always can react, or rather proactively address these limitations instead of reacting to this. So to understand why we have such shortfalls, we have to not just look at the technical aspect of how a drug is made, but also the technical and economic aspect of how drugs are made. So to do that, let's just take a quick walk through how a pharmaceutical is typically designed, manufactured, and sold to us. So it starts off with some essential need that we identify in a research lab on what needs to be given to a patient to address a particular critical healthcare situation. So we design drugs in a lab, and then we make small batches, and then we do a lot of testing on animals, people, before we get it out to the market. And then drug companies start manufacturing them in large quantities so that we can market them at an affordable price point. There are no shortcuts in research. We understand that. There's also no shortcut in testing the efficacy of a drug. But what drug manufacturers do is they try to take shortcuts in manufacturing. In other words, they try to beef up the technology for manufacturing these drugs so they can make them at a much more affordable price point than what was in the first batch. So to do that, they do what is called as a batch process manufacturing. So let's say that you've got some interesting molecule that is a drug product, and it has 10 or 12 reaction steps that needs to be completed to make it. They put them in these big vats, these containers that you see on the picture. And they move them through one after the other, and they optimize the process in such a way that it is efficient, cheap, affordable, and more importantly, clean and precise for what we want. But now, what we are doing here is we are creating this massive ecosystem where we're moving one component from one batch to another and to another, and we're creating all these points of failure in our supply chain or the production of a drug. And when rolling waves of shutdown hit the market, we ran into a short supply for all these critical medicines. So now the combination of technical and economic factors became a bottleneck for protecting the public, the general public, during COVID. But again, we have to understand that this problem of logistics and supply chain is not just unique to the commercial market. DoD has been facing this problem for a really long time. You know, Dr. Jeff Ling here, who was a program manager and an office director at DARPA at some point, he had the same situation while he was deployed in Afghanistan. And at the time, we again had this supply chain issue with essential drugs, simple things like, you know, ibuprofen or Tylenol, acetaminophen, and things like that. So at the time, DARPA premised that, look, such problems are going to be pervasive for the DoD, and we'd not even think about that being a problem for the general public in the commercial space, but it became a problem. So we, at the time in the DoD, we were developing a solution to manufacture drugs at the point of need and at the point of demand. So the answer for that came out to be what is called as a continuous flow reactor for manufacturing drugs or fine chemicals at the point of need. So you can think of a continuous flow reactor as an assembly line for making cars. We all understand that, right? Ford brought in this assembly line concept and revolutionized how cars were made cheaper, faster, and better. You can think of this continuous flow reactor as just another assembly line, not for a car, but for making these active ingredients or pharmaceuticals that can be chemically produced at scale. So the inlet has a bunch of reactants that go in. In this case, I'm showing an example for one of the molecules that is being made. And as the molecule and the reactants just go through the tube, it reacts continuously, and then out comes the products. And from that, you can separate the ones that you want, kick out the ones that you don't want, and just have a finished good, a finished product here. So the technology was in the chemistry of how these reactants react inside this flow reactor. And we did that by adjusting the molecule composition, volume flow rate, temperature, pressure, et cetera, and the magic was done. So this continuous flow reactor became an answer for us to make drugs at scale, cheaper, and at the quantities where we needed it, and again, where we needed it. So now this became an important toolkit for us to make not just small batches, but we can parallelize these continuous flow reactors in such a way that we could make larger quantities and rapidly scale up to address any abrupt supply chain disruptions. And this is exactly what we did with the Make It program. Now, Make It program was not standalone. I just wanted to walk you through this history of various programs that DARPA had invested in, starting from, on this chart, 2013, but even it predates that, where we were looking at how we can make chemistry more advanced, as in bring chemistry to the 21st century. So there were a lot of legacy programs that looked at how we can do battlefield medicine, pharmaceuticals on demand, American-made precursors on demand, and all these things led up to a point where we said, look, we now have enough knowledge for Make It program in 2017 to launch it so that we can create pharmaceuticals, really important pharmaceuticals on demand. It was originally designed to be a 3 to 4 year program, and then when 2020 came around, we were stuck. We didn't have enough pharmaceuticals in the commercial space. So DARPA, in collaboration with Health and Human Services and ASPR, another office within Health and Human Services, pivoted the DoD investment, the DARPA investment for making pharmaceuticals for warfighters, and turned it on to the commercial market space. So one of the performers on that program became a well-established startup, and they now have a factory where they can produce some of the key pharmaceuticals that we want for protecting the general public if there were to be an abrupt supply chain disruption. But again, this particular performer has pivoted further out into the commercial space to look at what molecules or what drugs can be made for profit at scale and based on the demand for the market. So there are a bunch of things that are listed here. They're all real, and they're all things that the Make It program has delivered up until now. In addition to that, DARPA is also looking at transition opportunities just outside of DoD use case. So we're now looking at, funding support from Office of Naval Research and Navy and Marine Corps. We're looking at how we can take this and put it on the deck of a ship, so we can not just make all these muscle relaxants and other anesthetics. We can also how we can make, antibiotics and other molecules or drugs that are important for war fighters. Now, on the shoulders of giants, Make It has now demonstrated that we can now shrink the global footprint of how we make pharmaceuticals to a single facility through the use of continuous flow reactors. Instead of having those big vats that sit in distributed factories all around the world, we now have multiple continuous flow reactors that are sitting inside a room in a factory where they can produce pharmaceuticals on demand. And I would also want to kind of share with you what I envision of the future to be. So now once we have shown that we can make pharmaceuticals on demand at the point of need, say for example, at a factory, we have now overcome the challenges with resilience, and we have broadened resilience at a national level. But then again, we have a lot of underserved communities around the country where supply chain is still a big deal for them. So for such instances, I envision the future to be where we can create these units, continuous flow reactors, with much more advanced technology through commercial funding and other transition opportunities to create resilience or build resilience at a regional level where, for example, a county can have this particular hardware, make it hardware, to make pharmaceuticals on demand when there is going to be an abrupt shortfall in supply. And zooming past into 10, 20 years from now, I envision that this technology can be further miniaturized to the point that you can have it either in your pharmacy or you can have it in your benchtop at home, so you can clearly take the learnings that we have from today and look at personalized medicine and precision medicine with a much higher level of sophistication than what we can imagine today. With that, I would like to thank you for your attention, and I think it's break now.